So I'm Sam. I am the clinical nurse trainer for Flen Health, and I'm going to be talking to you today about how to dress your lower limbs to optimise getting the best treatment for your patients. And then Astrid is going to talk about the medical side with the AMR, and then Louise will be talking while I'm doing the demonstration on a lower limb regarding how to use the flaminol and which one we would use in and why you would be using them. So when we're looking at wounds and dressing a wound, the first thing we need to do is always consider doing our full holistic assessment. And that goes without saying. Our very basic fundamental things that we need to start with is our full holistic assessment, including our physical wound assessment, our environment that we're dealing with, and also our psychosocial aspects of the patient. Once we've considered all of that, then we can then be thinking about the dressings that we're going to be choosing. So some of the challenges when we're dealing with dressings: managing exudate, choosing the right dressing for the level of exudate. Can this dressing be used underneath compression? Okay, that's another thing. You know, a patient may have a lower venous leg ulcer and you want to dress it with an appropriate dressing. NHSI says, nice guidelines say that we need leg compression, but can it actually go in compression with maybe your primary dressing? How do I dress these leg ulcers if they're not in compression? Difficult to dress areas, cavity wounds, maybe you've got wounds in between the toes, a fungal infection. How are you going to dress those? And we'll be demonstrating. And then also controlling bioburden and infection. So when we're looking at all of that full holistic assessment, it's only then that we look about our wound assessment. So you don't go to the cupboard straight away and get whatever dressing's available to you. We need to be completing some form of wound assessment. And the one we have here is the time assessment. Has everybody heard of the time assessment? Yeah. So today we'll be mainly focusing on the eye. But if we just run through it, just to recap for ourselves. So T, what is the tissue like? Is it healthy? Is it granulating? Do I have visible devitalised tissue? So again, putting your aims and objectives in place. Have I got devitalised tissue there? Does it need to be removed? What products have I got that is going to aid that getting rid of that devitalised tissue? Then are there signs of infection or inflammation? And I'll cover that one shortly. Apart from our arterial ulcers, which we're going to try and keep dry until after surgery, or maybe our end-of-life patients, we're going to try and create the optimum moisture balance, which is moist. We don't want it being too wet, we don't want it being too dry. And we also need to understand that moisture and exudate is normal part of wound healing, but too much or too little is going to delay that wound healing. So we need to choose a dressing that's going to actually able to create either absorption or aid autolytic debridement with the moisture balance. Look at the edges of our wound. Are they rolled? Are they undermining? Is there tunnelling? What does our edges of our wound? Does it look healthy? Are they migrating across healthy? And then the surrounding tissue. Now, I always say with the surrounding tissue, the skin is the largest organ and it can give us a lot of clues about the overall health of the patient. So not just the surrounding tissue of the wound itself, but if the patient had really dry lips or dry overall skin, that could be an indication that the patient may be dehydrated. Now, if the patient's dehydrated or malnutritioned, it doesn't matter what dressing you put on the wound, you're going to have some form of delay in wound healing because the patient's dehydrated or malnutritioned. So again, you need to take in aspect all of these to then be able to choose what dressing you're going to be using. So now we go back to the eye, looking at infection versus inflammation. So whilst infection and both immune responses, they differ in their cause and their purpose. And we need to know the difference between, is this wound infected or is this wound in a normal phase of wound healing, which is inflammation? Is it in a chronic phase of wound healing, which is inflammation? So infection is caused by the presence of pathogen and is aimed at eliminating it from the body. And inflammation is a non-specific response to tissue damage or irritation, regardless that there's a presence of the pathogen within that wound bed. So understanding the difference between normal inflammation of a wound bed and also is this infection is going to aid us to get the right treatment in place. Would you agree that sometimes patients may go to a GP with a wound that appears the same signs and symptoms of an infection, but it's not? It could actually be inflammation or chronic inflammation, but is prescribed antibiotics. Yeah? So at that point, we know that the overuse of antibiotics is there. And then Astrid is going to be talking about AMR and also antimicrobial stewardship and the safety side of using Flaminol as an antimicrobial. So here we can see the signs and symptoms, and you can see why there is an overprescription of antimicrobial dressings. So if we've got inflammation and infection, so inflammation, local swelling that decreases over time. So that patient that has the swelling, it should be reducing over time. Pain and worsening on stimulation, increased skin temperature, loss of function and movement to the wound, and then we can see in the exudate levels we've got thin, clear, amber or straw-like. They're normal exudate that comes off a healthy wound. And then we've got infection, persistent swelling that doesn't decrease over time, or it may be spreading. Increase and continuous pain. So the pain is not going, it's always there. It's not just on movement or just at the dressing change. The patient is constantly in pain with this wound. Loss of function and movement to the surrounding skin or the area that's had the wound. If that healthy granulation tissue is then, now you're going back, the patient may have increased pain. It may be that they've had increased exudate levels, but also when you're cleansing the wound bed, that granulation tissue is now starting to bleed very easily. That could be a sign of infection. So the wound is really starting to break down. So a few weeks ago, it was looking really healthy, but suddenly pain's increasing, exudate's increasing. There's a bit of an odour coming off that wound. We've got thick discharge, cloudy, milky green, yellow or brown discharge, exudate. Again, those can all be signs of our infection. If we think we've got a wound infection, we need to be treating it and not delaying, but then we don't want the overprescription of antibiotics. So how do we get around making sure that we've covered our infections, but not overprescribing antimicrobials or antibiotics for patients? So this is where Astrid's going to come along and talk to you about antimicrobials and the safety side of Flaminol.
Can you all understand me well? Yeah? Top, that's good, because we're going to deep dive into the infection side of things. Last year's publication in the Journal of Wound Management said the following. In up to 40% of chronic wounds, wound infection is the trigger of a prolonged or chronic healing process. When we then look at the specific types of bacteria, we know that in leg ulcers, the main or leading bacterial species are MRSA, methicillin-resistant Staph aureus, Pseudomonas, as well as Enterobacteria. When we look into DFU, diabetic foot ulcers, we see that also fungi can be a problem and cause problems like Aspergillus niger and Candida albicans. Now, talking about antimicrobial products and compounds needs us to talk about AMS2, antimicrobial stewardship, and about resistance and bacteria getting smarter than the therapies. Now, you might recognize this person on the slide. Voilà, exactly, Sir Alexander Fleming. He was he invented penicillin, the world's first broadly used antibiotic. And already at that time, he warned us. And he warned us with saying the following, and I quote him here: "There is probably no chemotherapeutic drug to which in suitable circumstances the bacteria cannot react by in some way acquiring this fastness." And that's amazing, because already at that time, this guy was saying us, bacteria are smart. And there is something what is called, he called it fastness. We know it today as resistance. They're finding out strategies and ways to circumvent our antibiotics. He warned us, and look what happens in the years after. every time we human beings put a new antibiotic onto the market, antibiotics like penicillin, streptomycin, tetracycline, a couple of years later there was a bacterium reported, for example, here in the case of tetracycline, 9 years later after introducing the antibiotic to the market, that showed resistance to the antibiotic. And that is a huge issue. It's a huge issue in many domains. It's an issue in lung infectious diseases, in bowel diseases, and as we're here today, we're talking about wound care. And unfortunately, it's becoming more and more of an issue too in our domain, in the wound care domain. Luckily, we have a lot of consensus and guideline documents. We have the one from EUMA from last year, an updated document on antimicrobials and non-healing wounds, where they tell us, they ask a question there, is there any antimicrobial agent that is not expected to select for resistance or tolerance in bacteria in the wounds? An interesting one to think about and to reflect on. The answer from EUMA is the following. Well, eventually, it is likely that resistance will develop against any topical antimicrobial. And that is again because these bacteria, they are clever. They are very intelligent and they find their ways to circumvent antimicrobial therapies. Though they give us some advice. They say, okay, all wound care companies having an antimicrobial bit in their products, please do this continuous and proactive monitoring for resistance. That is a must to be ahead of the bacteria. Now, let's look into Flaminal, because in Flaminal there is one element, and we call it the GLG enzyme system, that is an antimicrobial element. How does this work inside Flaminal? It works with two enzymes, glucose oxidase and lactoperoxidase. I tend to compare these enzymes with small factories, a factory that needs inputs to create, manufacture something and then create output. The very first enzyme is such a small factory. Glucose oxidase needs water, oxygen and glucose to start manufacturing and developing the output, and that is hydrogen peroxide. Inside Flaminal, hydrogen peroxide is the intermediate, because the second enzyme inside Flaminal, the lactoperoxidase, needs again the hydrogen peroxide to start manufacturing and produce the output ROS, or free oxygen radicals. Now these compounds, these radicals, they are interesting because they contain a super high amount of energy, and with that energy they fly and bump into everything that they come across, including the bacteria being absorbed inside the Flaminal. So they fly into microbial cell walls and therefore destruct them. There was one issue that we had at the time when we developed the Flaminal, that was that these radicals, they were very unstable. Because they contained such a high amount of energy, they were there for a fraction of time and they were gone. So we had to add an extra molecule to Flaminal, guaiacol, to stabilize these radicals and to give them a higher chance of destructing microbes, again, all happening inside the Flaminal matrix. It was a lot of theory, my apologies for that. We tested this in practice too, inside some bacteria that you might know, gram-positive like Staph aureus, gram-negative like Pseudomonas, as well as fungi, Candida albicans. And we saw that the enzyme system, the GLG enzyme system, was effective to all of them listed here on the slide. Now, back to the advice from EUMA, the European Wound Management Association, because they say, okay, you companies, you have an antimicrobial bit inside your products, you should do proactive monitoring for resistance, because resistance will eventually happen, and it can happen every day. So what do we do inside Flen Health? Well, we have our R&D team, and they're doing some what they call training experiments. They train the bacteria to evolve and become smarter than the enzyme system. We do this in an in vitro, so in a proactive setting. It's constant reculturing of these bacteria. The outcome of this experience is shown here in this graph, and that is where you can see that after 100 cycles, or 100, you can say, dressing changes, we see that all these three species, so the bacteria Staph aureus and Pseudomonas, as well as the fungi Candida albicans, they remain sensitive to the enzyme system. So even after 100 dressing changes, they're being killed off by the GLG enzyme system. Luckily for us. Now, we went looking into these reactive oxygen species because we said, okay, it's interesting that this comes out of these training experiments. How can this happen? We know that these oxidase, peroxidase, catalyzed systems are naturally occurring systems. They're part of us, even human beings. They're part of our saliva, our macrophages, our blood cells. Moreover, we know that the ROS, they target multiple types of bacteria, so gram-positive, gram-negative, as well as fungi. And then the most interesting part of it is the following. You see that these ROS, also here depicted on the slide, are different types of specific radicals that are formed. Different types of radicals with all having their own targets inside the bacterium. So some target like a protein in the cell membrane, some target another compound of the cell membrane, and some target another element inside the bacterial cell. So you can imagine and feel that for a bacterium, it's super hard to find or come up with a strategy to circumvent this. And that is why we can say, well, look, in our case, the GLG enzyme system is not prone to trigger emergence of resistance. Now, having said that, and I told a lot, sorry for this, I'm going to invite you to the front because we're going to do a little demonstration of laminal application. So if it's okay for you, you can all come to the front and you leave your microphones with you. We're going mic free. Sorry, Sam. Let's make a big circle here if that's okay for you so everybody can follow.
So you won't need your headphones because you should be able to hear me anyway. So obviously this is just your demonstration. Okay, it's not a training exercise. That's why we've got no gloves. We're not doing an aseptic technique. Okay, it's just to show you how we would apply Flaminol easily. Let's say on an infected leg ulcer that's very wet. So again, you've got your Flaminol Forte, and Louise in a moment will go through the mode of action and why we choose which one. Just take the one backing off it, okay, and don't take the other bit off. So while I put this on Adam's leg, Lou's just going to run through the mode of action and the reason why I would choose Flaminol.
So Sam's chose to use Flaminol Forte here, but we have the Hydro as well. So we have the two variants of Flaminol. So they're both fully antimicrobial. As Astrid's just said, it's an enzyme-based antimicrobial. So you've got the two enzymes stabilised by glycol that produce an oxygen species. With it being an oxygen species, that means it's equipped to deal with all different kinds of bacteria that you've got. You've got the debridement gel, so it'll help keep your wound bed clean, so that when you're doing your observations, when you're assessing your wound, it means that with the continuous autolytic debridement that we've got, your wound bed should be really clean and you should be able to see it completely. The only difference between the two products is that the Forte, we've added extra alginate in. So the reason that we've done that is to help deal with your higher exilium wounds. So for example, if Adam's leg needed the dressing changing every day or every other day because it was so high in terms of the moisture levels, you would start with your Flaminol Forte. So obviously because you've provided the wound with an antimicrobial, you're constantly debriding it, and you've got your moisture balance there with the alginate, at some point this wound won't require such high levels of alginate. So at that point you can switch down to the Hydro and continue using the same treatment plan. So it just means you've got consistency of care, so it just means that you can switch up and down between the two. Obviously patients can do a little bit of shared care if they need to as well, because it's completely non-cytotoxic. Okay, so you've got those two on there.
And then for here, so I've applied the Flaminol by using the secondary dressing to be able to manage it. Then all I would be doing is moving it into place, so it's a pound coin thickness all over the wound bed that I need to be treating. So a pound coin thickness all over the wound bed that needs to be treated. And then I'd been using a secondary dressing purely to manage the exudate levels. Okay, so if it's low exudate, say you've taken some staples out and there's just a small area that hasn't knitted together, then I may just put a bit of Flaminol Hydro and just a post-op surgical dressing. Okay, the higher the exudate, that's when I'm going to be using the secondary dressings to manage it. So then I'd just pop your secondary dressing on and then bandage his leg up. Let's say we were doing a diabetic foot, which has got visible tendons or ligaments. Lou will show you the difference. She spoke to you about the Hydro and Forte, but you can use the nozzles, okay? And that's really good if you want to pack, say, a pionidal sinus, you've got a track in, you've got undermining, and you can then just apply Flaminol. And then on top of that, you just pop your secondary dressing over the top. Again, you do come with nozzles if you want them. They just screw onto the end of the Flaminol. But with the nozzles, syringes, it's really good if you want to measure volume. And then if you think of it as like a child's balloon, you're filling it up. You can't overpack it. Once you've squirted it all into that hole, it will pop up to the top. But you can guarantee Flaminol's got into all the nooks and crannies. So there's no dead space where you've not got Flaminol covered. Okay, and then you can measure volume. So if you put 5 mils in today, Adam is not a clinical nurse. If I could only put 5 mils in, he would only be able to get 5 mils in. You can't overpack, you can't underpack. So really good for shared care as well. So yeah, but if you put 5 mils in, don't expect 5 mils out, because you won't. All right. I shall pass you over to Lou.
You can use a spatula, obviously, to apply it to the wound bed. I always think if you're dressing a leg ulcer or something bilateral, it's a really good idea to put it onto the secondary dressing, just so that you can obviously make sure that you get it underneath, over the top. Obviously it's a gel, so imagine trying to pop it onto a wet leg, it would be quite difficult. So I would always use, like Sam said, your secondary dressing with your £1 coin thickness, which is your gold standard. The syringes, please take the plunger out the back and pop the Flaminol in. You will not be able to draw it up, it's too thick. And like Sam said, great for recording your volume for your notes. We know how important documentation is, so it just means that you've got a volume measure there. You can also, like I say, use it directly from the tube. As long as it's recapped, Flaminol's fine to use for up to 12 months after you've opened it as well, so please don't throw it out. As long as it's recapped, it's fine to use. And like I say, patients can get involved in shared care as well. So whether they're using maybe like a syringe to top it up, or you're giving them some dressings to take away, you can do that as well. Okay.
Any questions?
Just want to find out. So, like the horn, if it gets to good skin, it breaks it down, and Flaminol.
No. So if Flaminol, obviously, if you've got devitalised tissue in your wound bed, which Flaminol's going to promote autolytic debridement, I always say make sure that you've got a barrier product around, because it's the devitalised tissue that is autolytically debriding off to go into your secondary dressing that will macerate your surrounding tissue. Flaminol could sit on Adam's skin all day long, and the only thing you may see is like white crystals, and that's just dried up alginate. It's not going to harm the wound, it won't do any damage. Just clean it on the next dressing change, and that's it. If you see white crystals in the wound, you're probably using the Forte, and you can change to the Hydro, okay? But no, it won't macerate or overhydrate the surrounding tissue. Just make sure that you use a barrier product. If you're trying to get rid of any devitalised tissue within a wound bed, we should be using barrier products. Yep.
If you get into a cavity, I know how you said 5 mils in.
Yep.
So do you have to try to get a bit out, or
no? Just top it up.
Do you irrigate it then?
Best practice now says we must irrigate and cleanse each dressing change, but with Flaminol it would just be what surface you can see.
Because some like tunneling wounds, like a wound that's tunneling, you probably not be able to get it.
you just irrigate as you would, and then just retop it up.
You probably just maybe need to think every other day, or it would need to be done, because of the way that Flaminol